Thank you, Sain. So from here, I'll elaborate what we have done so far in Nepal in terms of medical genetics need assessment. So initially, we devised a 42 items qualtrics survey, and which mostly included demographics, family health history, and regarding genetic conditions, capacity, and desire for future services. Those 42 items included the following things. They were then electronically distributed to physicians, providers in Nepal, and till now more than 160 Nepalese physicians, they have completed this survey. So in total, we have received 148 completed surveys, and most of the average age of the physician is 33.8 years, and the age ranges from 24 to 47 years old, and most of them are female, 54%, and 46% of them are male who participated in the survey. And the physicians who participated were mostly from medical and surgical specialties, and other than that, there are also representatives from pharmacy, nursing, dentistry, and physiotherapy background. And we also included, we distributed this survey to all the provinces in Nepal. So in Nepal, we have currently 7 provinces. So we wanted to make sure we receive the responses from physicians all over Nepal. And till now, in the survey, there was participation from 32 different institutions. So there are 2 components, basically family health history and the genetic services. So in terms of family health history, we asked if the physicians, they obtain family health history while caring for the patient, and most of them, they agree and strongly agree that they do obtain family health history. And they are also very much confident about their ability to collect family health history during patient care. But when we asked if they construct pedigree while taking family health history or not, then there are 30% they agree, but a little less than 30% they mostly disagree, to neither agree or disagree. So I think those who constructed the pedigree, those who took the FHH, they would construct the pedigree as well. And those who took the pedigree, they were also able to produce and interpret the pedigree. So these were the 4 questions from family health history part. And moving forward, there were most questions from genetic services. So we asked whether the physicians were seeing patients with confirmed or suspected genetic conditions. So most of the providers were uncertain if they were seeing patients with genetic conditions, but then if they were seeing, they would see them annually or monthly more, and not in a daily and weekly basis. So we also asked if they ever ordered a genetic testing, because after COVID, PCR testing has been common. So we wanted to make sure that apart from PCR testing, what kind of genetic test those physicians they ordered. And most of them, around 70%, they said no. They don't order genetic testing on patients in Nepal. But however, they think genetic service do play a significant role in their clinical practice. Around 50% they think, they agree that genetic services do play a role in their clinical day-to-day practice. And then we asked if their ability to get genetic testing completed on Nepalese patients. As you can see, more than 60% they think that it's very difficult, and more than 20% difficult to very difficult. So most of them say it is very, very difficult to get the genetic testing completed on Nepalese patients. And we also asked if their institution or where they are working, if there is any availability of genetic tests being done. Then most of them said none, but less than 5 they highlighted karyotyping as common testing, but mostly they think they don't have genetic testing available at their institution. So we were wondering about what are the difficulties for physicians and providers of getting genetic tests done in Nepal. So as you can see, most common it is the unavailability of laboratory where genomic testing can be done, similarly cost of the testing, and logistic of the testing, where the common barrier which they would encounter in terms of ordering the genetic test in Nepal. So I think I'll let Dr. Shane continue moving this forward.
Yeah, so we also did collect some data on other things that we didn't analyze, and so this was just sort of a preliminary analysis that from the data from September before, so up to like September 1st. So we've also collected other aspects of practice that people may have, confidence with providing genetic services, and then also patient and family interest. So that's all stuff that we're going to look at further as we sort of collect more surveys. Sort of easier access to genetic testing was really the most commonly listed barrier that people identified as the sort of way to actually improve genetic services in the country. And the other thing that I'll highlight that's really useful is we actually did ask if people are interested in getting involved with this. So we sort of started forming this little network of providers who've expressed interest in these services going forward, which I think is another important aspect when we sort of grow these services in the country. So overall, as to sort of summarize these things, Nepalese providers are seeing patients with genetic conditions. There are clearly additional services that are necessary to move the sort of needle forward as far as genetic services in the country, and the sort of genetic testing was actually the main one identified. We have other things that we're going to work on going forward, but like I said, that network of interested providers is going to be incredibly important going forward. And just a couple more slides I'm going to mention. I already highlighted this as well. So when we think about moving this forward, this is a fellowship at the University of Michigan. It's called the Joseph Matnovic Endowed Clinical Fellowship. This is at the University of Michigan, and this has just been offered, and I was able to apply for this grant or fellowship for Pratiksha, and we sort of successfully had it awarded, and we sort of made this fellowship. The application we put in was to train Pratiksha on molecular genetic techniques. So she will be spending 6 months at the University of Michigan learning MLPA and Sanger sequencing, 6 months back in Nepal, and then another 6 months back in the US learning NGS. So another important aspect of the sort of bi-directional relationship that I think we have. I've listed a couple other future plans there that are things that we're thinking about. For the sake of time, I'll keep rushing through. And really sort of lessons learned, then I'll stop with this. A good relationship between collaborators is really paramount here. It's really the most important thing of this. Local capacity is not the easiest thing, but well worth it. And increasing interest in medical students and trainees has also been really beneficial for my end. And then my sort of favorite quote in the world that I'll sort of throw out here is, most people really overestimate what they can do in a year and underestimate what they can do in 2 or 3 decades. And I think that that's going to be a really important aspect of this when we all think forward, because this clearly isn't going to be done next year. So this is some acknowledgements that we really, really want to highlight, because these people are really, really important. I'll let you read through them, but we'll sort of stop them now. And we really, really appreciate the opportunity to talk to you guys. Thanks so much.
Thank you so much.
Thank you very much. As Theodora mentioned, we'll keep the questions and answers for after all the talks. And so I have the pleasure now to introduce Dr. Trang Pham, who is a young medical doctor trained in pediatrics and PD neurology in Vietnam. She is strongly committed to implementing genomic medicine in Ho Chi Minh City. And over the last 3 years, Dr. Trang has been involved in a Swiss-Vietnamese collaborative research project on the genetic causes of severe childhood epilepsy under the mentoring of Professor Christian Korff over there and myself. And so without further ado, Dr. Trang, please.
Thank you, Professor Mark Abramowitz. So, good afternoon, everyone. My name is Trang, and I'm a pediatric neurologist from Vietnam. And until now, Vietnam is still classified a low-middle-income countries where genetic investigations are still limited because of its high cost in Vietnam. But fortunately, on the basis of long collaborations between Switzerland and Vietnam, particularly from Geneva University Hospital and Children's Hospital 2 in Ho Chi Minh City. We have conducted joint research about pediatric epilepsy in children, and I'm so excited today to present our study as an example from Vietnam. So my outline here today, first we have a brief introduction about how genomic medicine is applied in pediatric epilepsy, of course. And after that, we'll dig a little deeper about the methodology and how we conducted the joint research between two countries. And after that, we want to share about our expectations and future insights. So about the global burden, the active epilepsy affects nearly 50 million people globally, and the prevalence in Vietnam it lies between 300 to 1,400 over 100,000 per person. Despite of its very low cost of not high cost of the anti-seizure medications, up to 75% of patients who are diagnosed with epilepsy in Vietnam do not receive their proper treatment, and this treatment gap concerns as 85% in Vietnam, Vietnamese patients. So due to its burden, as you can see there are a lot of complications that are associated with the with the global burden of epilepsy, and of course it leads to the decreased quality of life and poor health outcomes. So about how genomic medicine is applied in pediatric epilepsy, numerous studies have shown that early childhood, especially in the first year, is one of the two periods of life that in which the risk to develop the disease is the highest, along with the elderly people. And with a lot of different underlying etiologies, different from the elderly group, the genetic cause or the presumed genetic cause are much more common in children at onset. And as now with the development of precision medicine, particularly in the genomic medicine, several pathogenic variants have been found with established targeted therapy in the pediatric epilepsy. But some of these variants are just a small proportion as compared to the continuously growing variants detected by recent techniques. So the NGS, as the next generation sequencing, is widely known for the best approach in screening for single gene mutation, especially in pediatric epilepsy. It includes clinical exome sequencing, whole exome sequencing, and whole genome sequencing. The West is relatively used recently for detecting de novo variants. We can see it in, there's a landmark report, but it was published by the International Consortium EPI4K in 2013. And in that study, 264 patients, children, they were analyzed with their parents in the trial analysis. And in this study, 429 de novo variants were identified. The West is also known for its cost-effective because we can see it in many studies. For example, in the Palmer in 2018, when he evaluated the cost of the two diagnostic approach model between the diagnostic view between specialized neurometabolic investigations and the West, and it shows that the diagnostic yield for the second tier investigations as the specialized neurometabolic investigations is just 6.2%, as opposed with the up to 50% of West diagnostic yield. And about the treatment adaptation, another studies have shown that Simon have presented a cohort study in Simon has, sorry, I forgot where the study is, but yes, in 2019, his study showed that 64 over 80 patients have their could receive the individualized therapeutic treatment in pediatric epilepsy. So for all this reason, it is quite reasonable for us to conduct our genetic investigation in children with developmental and epileptic encephalopathies in Vietnam. So our constructive collaboration has been established since 2015. Formerly with Professor Pierre Jalon, he's a former head of the epilepsy unit from Geneva University Hospital. And during his visits to Vietnam, along with Professor Christian Croft, lately dozens of in and out patients were examined and discussed with doctors from Vietnam. And we also have organized many teaching symposiums, and also the teleconsultations are still being used as our regular basis until now. So in the scope of our study from Vietnam, we have the strength of an easily accessible and a large patient population with ethnic diversity. But however, due to the high cost, the genetic database has not been collected widely over Vietnam, and also because of the lack of our expertise in clinical genomic medicine and equipment and facilities, that are our limits. So with the opportunity to collab with the Geneva University Hospital, we could conduct our research, and it's an opportunity for us to approach to a diagnosis for our patients. So our research plan will consist of two main goals. The first main goal is that we will establish the proportion of children with developmental and epileptic encephalopathies, and we expect this number to be 40%. And the next goal is that we want to find out the proportion of children who can receive the individualized treatment adaptations, and we expect this number to be 10%. And the parallel analysis of patients' exome sequencing will optimize this procedure. So about the methodology, the first phase is in the patient recruitment. So doctors from Vietnam, we will examine the patients who are less than 36 months old, and we will collect the data from the medical report and have a monthly discussion with the pediatric neurologist as Professor Croft in Geneva online, and we will select which patients has meet the selection criteria. And after that, the blood samples will be collected in Vietnam, and we will do the DNA extraction and also the DNA sequencing to export the raw data as in FASTQ format. And this raw data after that will be sent to Geneva, particularly Genomic Medicine Unit in Geneva, for the parallel bioinformatic analysis. And after two teams have reached the step of variant prioritization, the Genomic Medicine Unit in Geneva will host a virtual genome board online with the multidisciplines attendance, like the physicians, pathologists, radiologists, medical biologists, bioinformaticians, coordinators, and medical geneticists. And with patients who have their variants classified, they will then be adapt a treatment individualized based on the literature review. For those who have unclassified variants, they will then undergo additional testing or investigations afterward as needed, or they will be reassessed after 18 to 24 months. So these are some photos of our collaborations until now. On your top left photo, you can see that there's the meeting hall in our Genomic Medicine Unit for the Genome Board with Vietnamese clinician is on the screen. And we have Professor Christian Karv as the head of Pediatric Neurology Department and Professor Mark Abramovich, head of the Genomic Medicine Unit, to come to Vietnam in their visits and with educational meetings. So until now, current results just from June 2022, 70 patients have been enrolled and nearly 120 candidates are on pending list for selected into our study. And 7 genome boards have been hosted with 32 patients were analyzed. In 8 cases, over 32 patients have classified variants as pathogenic or likely pathogenic, and 12 over 32 patients are in their further tests to confirm variant classification. So for the expectations and future insights, we believe that this project would be enormously beneficial in any ways, in many fields, like from the aspects of patients in their treatment in genomic medicine, for healthcare practitioners, for us to understanding better in the genomic medicine, and for the whole system for the human genomic database, especially from resource-limited countries. So finally, we would like to send our most sincere thanks to the Swiss National Science Foundation and Geneva University Hospital from Switzerland, and FOSTED as the National Foundation for Science and Technology Development and Children's Hospital 2 from Ho Chi Minh City for their relentless effort in this project. Thank you.
Thank you. Thank you for the great talk, great data, great effort. So now I'm very pleased to welcome Dr. Carvill, Gemma. She's going to talk to us about her role applying genomic medicine, also tackling pediatric epilepsy, this time in Africa. Thank you.
Do I need to kick it to make it work? All right, perfect. Is that looking okay there? Oh, I've got a bit of the top to cut off, but I think it'll be all right. Shall we see? I think it's going to be fun. It's just the first one. All right, so hello everybody. Thank you very much for the opportunity to speak today. I'm here really representing what is a team effort, and so this is the wonderful team that I've been working with for the last couple of years. So myself based at Northwestern, pointer's not going to work. So myself based at Northwestern, we've been working for the last 8 years or so with a fabulous team down at the University of Cape Town. So Joe Wilmshurst is a pediatric neurologist there who has been working in epilepsies for many, many years. A fabulous clinician, a fabulous collaborator, as well as Alina Esterhuizen, who not only is the head of the Molecular Genetics Diagnostic Service, the NHLS, which is her regular day job, but she also managed to do a PhD side hustle for the last 8 years. And so a lot of the work that I'm going to be presenting today is really Alina's PhD thesis that we recently published, and this is an ongoing collaboration. So Trang very nicely introduced the epilepsies. I do not need to do that. Thank you very much. The thing that I will say is that it's not really epilepsy, but the epilepsies, and that it has a very wide phenotypic spectrum associated with the epilepsies. And really the disorders that we've been focusing on the most are the developmental and epileptic encephalopathies. And so these are the most severe end of the spectrum of the epilepsies. These individuals are very severely affected. It's a heterogeneous group of conditions. And I've named several here, so Dravet syndrome, SCNA-related epilepsy. And they are really, even though they're heterogeneous, they are really all characterized by very early onset seizures. These seizures tend to be daily, so some of these kids have tens to hundreds of seizures on a daily basis. And so because of this in the early onset, what tends to happen is that many of these kids can have normal development until onset of seizures, and then they can have cognitive either arrest and in many individuals decline as well. And so associated with this are many much intellectual disability, movement disorders, and other neurological disorders as well. And so because of the nature of this disorder being very severe, we knew early on that it was very likely that the vast majority of these disorders were caused by de novo variants. And so this will just give you a history of the epilepsy gene discovery. So really over the first 20 years or so, gene discovery in epilepsy was dominated by the channelopathies. So this was doing classic old school genetic studies in families and in certain syndromes, of course into NGS. And because we had a suspicion that many of these disorders were going to be de novo, we applied trio exome sequencing, and there was really this explosion in the discovery of many different types of genes for the epilepsies. I like to think now that we've kind of entered a gene matcher era, where now, as opposed to groups discovering genes, new very rare causes of these DEEs are really facilitated through matchmaker platforms like Gene Matcher. And so because of all of this wonderful research that's happened over the last 10 years, we now know that in the DEEs, most individuals, so about 50% of individuals have a genetic diagnosis. And so the majority of individuals, around 40%, have either a de novo variant or in some instances recessive cases of monogenic disorders. So this is a rare disorder, highly penetrant alleles. And then a smaller subsection of between 5 and 10% have copy number variants. And so as a result of this, particularly in the monogenic disorders, we now also know that there are precision therapies in at least 15 of these genes. And a genetic diagnosis in one of these 15 genes can really change clinical care in these individuals. And so to give you an example, the sodium channel SCN2A, if you have a gain of function pathogenic variants in this gene, what happens is that there's too much sodium is transported, and so you can imagine that and this causes epilepsy, and so you can imagine that if you use a sodium channel blocker, this may be an effective therapeutic. And indeed, individuals with these types of mutations do somewhat respond to these types of medications. Importantly, this is not a complete response, but moving from 100 seizures a day to multiple seizures over a week is already a big benefit for patients, particularly in their development at a very early age. And so this is the case in most HICs. When we started this project 8 years ago, there was absolutely no genetic testing for the DEEs in South Africa. And so Joe and Alina recruited a cohort of, we have much higher numbers now, but this was the first cohort that we reported, of 234 individuals. You can see there their inclusion criteria. And Joe and a very talented MD student at UCT built a REDCap repository for deep phenotyping. Because we knew early on we wanted to do this genetic testing, but we also wanted to be able to identify those individuals that were most likely to benefit from a genetic test. So again, thinking about implementation and finding those individuals that were most likely to benefit from these tests. And then in addition, we were able to capture the demographics of these 234 individuals and show that they were representative largely of the Cape Town population. And so we performed multiple molecular genetic investigations. So the entire cohort were sequenced for a 71 gene DEE panel. So these are genes that are well-established causes of DEEs. In a subset, so about 78, and honestly, this was primarily based on the availability of high-quality DNA. We did CMA with high coverage of those DEE-related genes. And then in 20, where we had trios, and I'm going to return to this point later, we also did exome sequencing. And so this table shows you the results. I'm going to walk you through the genetic yield for this entire cohort. So you can see I've broken this down by neonatal, seizure onset, infantile, seizure onset, and then childhood. And the first thing that I want to draw to your attention is that individuals with pathogenic variants in single nucleotide variants, the highest incidence, perhaps unexpectedly, because we saw this in HICs as well, was that the highest rate of genetic yield was in the neonatal and the infantile period. So you can see those numbers there. Between 26% of individuals in the neonatal had a positive genetic finding. Conversely, if we look at CNVs, we can see that our CNV detection rate was really across the board and was age independent. And so roughly about 5% of individuals had a pathogenic copy number variant. To note, we did these numbers over the entire cohort, but to remember that we actually only investigated 78, and so the actual number of positive CNVs in this cohort was 15%, which is actually a little bit higher than most other populations, and we have reasons for that, and I'm happy to answer questions about that. The main thing we noticed was that this pickup rate of 12% is much lower than what we see in HICs, which is closer to 40%. And again, we have several ideas as to why this may be the case, with one of the prevailing ones being that we implemented the ACMG criteria for pathogenicity. And so much of that criteria really rests on the inheritance pattern of that particular variant. And so in the South African population, we often struggle with obtaining DNA from both parents. And so that often limits our ability to move that VUS into the PLP category. And so we have at least 16 candidate variants that personally I'm very confident in, if we had parents, would probably be moved into the higher category. And I'll return to this in a moment. The other thing that we were able to do with our data set, and again because Joe and the master student did such a fabulous job on capturing a lot of clinical information in REDCap, was we could compare those individuals in whom we identified a genetic variant and those in whom we did not. And we can compare the different clinical features between these groups. And so what I'm showing you here are those individuals in orange in whom we identified a candidate CNV. In red, those individuals in whom we identified a candidate single nucleotide variant. Blue is a candidate in any class of variant. And green is the entire cohort. And so what you can see here in the first bar chart is that individuals who presented with global developmental delay before seizure onset were much more likely to have a copy number variant. And we can do that through a variety of different clinical features and see where the highest clinical yield is. And so for CNVs, delays before seizure onset as well as dysmorphism were highly predictive of us detecting a copy number variant. And similarly, with the single nucleotide variants, individuals who had autism spectrum disorders, and particularly those individuals who had movement disorders, we were much more likely to identify a single nucleotide variant in one of those genes. The other thing that we really wanted to take a look at in our data was the precision medicine implications of our findings. And so again, I've broken this down here in the neonatal, infantile, and childhood years. And you remember that I told you about 15 genes, roughly 15 genes, we know have precision medicine implications. And so this is often a change in treatment right now. We'll move towards gene therapy eventually. But right now, this is a change in treatment. And so you can see really in the infantile and neonatal stages, between 21% of individuals in the neonatal period, we could actually change their therapy based on their genetic finding. The infantile group is largely influenced by, we identified a lot of individuals with Dravet syndrome, so pathogenic variants in SCN1A, which has a drug indication. And so this was very encouraging, because the takeaway from this is that even if we look across all age groups, by sequencing this small set of genes, we found that over half have precision medicine implications and can change clinical care. This is incredibly important in a resource-limited setting, where individuals having an increased number of seizures means increased hospital visits, it means more ICU admissions, and so identifying a genetic variant early really can change not only that individual's and family's life, but also have huge implications in terms of the public health benefits as well. And so what is slightly discouraging to see is that if we look at the mean age of diagnosis for these individuals, and so you can see, despite the fact that there's an onset in the first month, these individuals aren't getting diagnosed until 10 years later. And so to be honest, a change in clinical care at that time point has very little impact on clinical care. And we had some great examples in our data set where there were 2 individuals who both had pathogenic variants in the gene SCN2A. And so in one individual, they were 12 years old already. And so when we said we found this particular variant, what we can do is switch up some of the medications. And the family was actually very resistant to it because they'd kind of been through this very exhaustive journey over 12 years of multiple medications. And they finally had something that was kind of okay. The patient was still having many seizures a day, but they had kind of accepted this as the status quo. Conversely, there was a very young individual within our cohort who was only 2, and there switching up their medications drastically changed the seizure burden in this individual, and they actually managed to acquire new developmental skills as well, which they never would have been able to before. So this is a really nice illustrative example of the power of changing clinical outcomes for individuals. And so we wanted to leverage these 2 pieces of information. So one, who are the individuals that are most likely to have a positive genetic finding, as well as in whom does the genetic diagnosis have the biggest impact. And so we came up with this idea of a Think Genetics tool as a workflow for identifying those individuals who are most likely to benefit from a genetic test. And this workflow could be applied it's being applied in South Africa, but could be applied in many LMICs. And so really we think any individual, so a neonatal infant that presents with refractory seizures and has these additional clinical features, so movement abnormalities, you can read them for yourselves, should be enough to trigger a specialist consult, upon which there is a review of the medical record and certain other tests ordered if they have not been. And then it kind of takes a 2-tiered, within that specialist consult, there are 2 different avenues that could be pursued. So in the instance when there are no dysmorphic features and development tended to be normal prior to seizure onset, a CMA might be indicated. Conversely, if the individual had normal development and no dysmorphism, then one might instead recommend a DEE panel. And so the panel that we're primarily interested in is a small panel of about 20 genes that have precision medicine implications and also high yield in terms of the number of genes we detect. And so from here, there are obviously a variety of scenarios that can occur. Best case scenario, we find a pathogenic variant. There's a MDT is a multidisciplinary team consult, precision medicine, change in clinical care, genetic counseling. In many cases, we find VUSs, and so there needs to be parental testing and other methods. And then there is, in the case where there are no pathogenic variants, at the moment what we're doing is a reflex to exome and eventually genome setting in a research setting. And so we think this Think Genetics tool can act as a framework for thinking about implementing genetic testing in the DEEs in Africa. And so moving forward, Alina is implementing the DEE panel in South Africa. Joe is continuing to refine this model through robust structural phenotyping. We continue to collaborate for sequencing on undiagnosed individuals. At the moment, this is performed in the US in my lab, but we are in the process of seeking additional funding so that this will be a collaborative study where a lot of the sequencing will be outsourced, but a lot of the analysis will start to happen in Africa where it should. And so keys to successful implementation, I've kind of listed some of them here that we think will be important to move forward. Many of these topics are what we're going to cover over the next couple of days, and so I'm very excited to hear other people's ideas and share ideas on how to make this happen. And then lastly, because I'm a computational molecular geneticist at heart, I also think a lot about what I bring to the table, and so it's really in identifying the missing etiologies. And one of the big things that we struggled with is resolving variants of uncertain significance. And I think this is true in America, this will be true across the world, and even more so where there's greater genetic diversity, and also in many scenarios there is a limited access to parents. And so I think we need to rethink how we classify variants in LMINCs and work with countries to see what is going to be best for their particular situation. I think the other thing that we need to do is leverage machine learning and MAVES, which is something that we work on in our lab, where we are using machine learning models to create gene-specific predictors of whether a variant will be pathogenic and benign. And I'm happy to talk more about this at coffee, etc. And then lastly, I think the other thing that we really need to push for is creating population-specific pan-genomes. I think we throw away a lot of information by aligning everything to the current human genome, and I think it'll be very important to switch this moving forward. And so with that, I will close. And again, big thank you to Alina and Joe who really drove this project.
Thank you very much, Gemma. I think we'll have many questions after the next talk, which I will introduce now. Professor Thong from the University of Malaysia was trained in pediatrics and genetics and established the first genetics clinic in Malaysia a few weeks ago, that is in 1995, just kidding. And MK sits in numerous scientific boards and received several top awards, including the 2022 Advocacy Award of the American Society of Human Genetics. He will speak to us about his experience in public health genomics in Asia-Pacific region. Please.
Thank you very much, Mark. Thank you to the organizers for having me today. It's a great honor to be able to come and speak. It's a wonderful opportunity indeed to meet so many old friends and make new ones. I'm actually representing most of my colleagues from the Asia-Pacific region, and that includes Pacific Islands to Southeast Asia and mainland Asia. But Japan, South Korea, and China has their own society, so we are basically just covering about 2 billion people. But nevertheless, when we first started genetics 25 years ago, and we sort of, and many of us are trained in Western developed countries, and I myself was very grateful, spent many years in Australia, and had a chance to come back home, and that's when reality sank in for most of us. No labs, no genetic counselors, and a very hostile bureaucracy against introducing expensive therapies and services which they felt that difficult to implement. And of course, most of us are familiar with this paradigm about genomic medicine, and you would probably have heard about the Angelina Jolie effect, where she, in a way, it sort of changed how medicine was practiced, even in middle-income countries, where we often are overlooked by granting agencies because we're considered as middle-income countries. So we are really caught in between, whereby we are not eligible for many of these grants. Nevertheless, the Angelina effect came into being because it sort of led to a surge in service demand by various population in the region. And that led to many governments, for example, to sit up and say, you know, we need to look at how genomic medicine can be done better in the country. And of course, with social media and easy access to information, the leveling of the playing field, many of this has been, this responsibility has been taken over by commercial entities, for example, direct-to-consumer testing, and what we call the retail genetics, trying to sell food supplements to improve your genomic profile. On top of that, we also had some of those more recent advances like newborn screening using genomic data. And many of these led to the question like who is providing the genetic counseling services, because there's very few of genetic counselors around and very few clinical geneticists. Now, most of us are familiar with this paradigm shift to setting up clinical genetic services, where these are the usual services that have been done. And with the advent of genomic medicine, the demand for service is even greater. And therefore, many of these discussions that take place in the Asia-Pacific region in the last 20 years has been centered upon some of these issues. But I'm very grateful to Professor Devendra, who actually invited many of us to contribute to his book made 20 years ago. And that sort of set off one of the impetus to get all together all our colleagues from Asia Pacific region, because he invited most of the main authors from the region, the leaders and so on. And we sat down and think and said, there are a lot of issues that we need to tackle, but what are some of the major highlights that we need to look at? And first of all is that there's very little local population genomic data from Asia. So if you were to do any form of artificial intelligence, machine learning, they're going to learn from sources that are not Asian-based, for example. Second, if you look at most dysmorphology database, right, whether it's face-to-face or any of these Western-based database, you find it very a challenge to diagnose an Asian person with a syndrome. And that's because there's a lack of Asian dysmorphology data in most of these databases. There are also ethical concerns that have been raised because of the lack of funds, and I say this sincerely because there's so many priorities. Many of these tests were done on a research basis. Now, that would not be considered ethical to be used in a clinical setting, right? But I'm sad to say that we do it all the time due to lack of resources. And many a times we are faced with errors in the laboratory interpretation and the diagnosis that's been made. And it's really a big challenge for us. And the cost of tests we have mentioned a couple of times. And the lack of recognition of the roles of genetic counselors is really one of the biggest setbacks that we have, and we're still battling this issue. And I raised it just now with Dr. Farah. And challenges with interpretation of genomic results by clinicians. And you know, we have a whole generation of clinicians who are not trained in genomics. And this is a big problem because it's a legacy problem. And many of these are holding senior positions in various institutions, in the Ministry of Health. And this is a big problem because they just don't see the benefit of genomic medicine. So, and in the last 5 or 10 years, we are now focusing on multifactorial conditions. No longer we are on Mendelian conditions. So we are talking about polygenic risk scores and so on. And the question has been asked about medical curriculum, which are increasingly being pressurized to increase more knowledge, at the same time cutting down on the time of training. So how do we reconcile all these challenges by a band of brothers and sisters in genetics? And on top of that, because of the awareness by our clients and patients and support groups, there's still a lot of issues relating to stigmatization and discrimination, and try to achieve equity in healthcare, not equality. And this is what politicians like to do. They want equality, not equity in healthcare. And this is the biggest problem because when it comes to expensive therapy, expensive tests, this would be at the bottom of the list. All right? And then in many countries in Asia Pacific region, the insurance has a almost godlike presence where it can determine who and who does not get coverage. And many congenital and genetic conditions are excluded from coverage, for sure. And we have difficulties with interventional, early interventional programs for people with genomic problem. There are various ethical, legal, social, as well as religious issues. This is an important part because a large part of Asian population has religion that do not allow termination of pregnancy, for example. And this has caused severe challenges in terms of counseling and providing support. There's also lack of genetic counselors and nurses, and support groups and advocacy groups are often frowned upon as troublemakers by politicians rather than partners. So, nevertheless, we work on and we try to focus on things that we can do, and that is policy making. We wrote up quite a number of policy papers, for example, championing equity in healthcare. Top of the list was sometimes what we call rare disease, and we put up some of these papers, despite not being popular publications among the political community. but nevertheless, there's a lot of press been gained by putting up this kind of policy paper. So for those in countries where you have no policies, you can actually write this up and you can actually put it online so that everyone has access to it. So one of the things that we really fought for was to recognize genetic counselors in their role and trying to put it that it's an ethical and safety issue, right? Because if you were to leave genetic counseling to untrained clinicians, for example, and I say this with respect to all my clinical colleagues, clinicians are poorly trained in counseling because they feel that it's all about genetic information. I often have to correct them and say it's not about information per se, but you're also talking about information supporting parents, supporting clients and families. And those are the things that often left out during their genetic information session. Yeah? And because of that, we got together and we started curriculum, genetic counseling curriculum. We worked with various genetic counseling society, including those from Australasia, the US, as well as Genetic Counseling Society of India, which has been very supportive. And you can see one of the papers that we have on the current status and the direction that we headed to. And one of the things that we set up was to put up a Professional Society of Genetic Counselors in Asia, or PSGCA, which is a special interest group of the Asia Pacific Society of Human Genetics, or APSHG, which was set up about 15 years ago. And basically what we have done is to train a dedicated core group of genetic counselors in the Asian region. And you can see that over the years, we have expanded, and there are now probably close to 1,000 genetic counselors spread across the Asian continent. But with a population of 3 billion, that's a drop in the ocean, right? So we have still a lot of work to do, but I think that we have lit the fire, so to speak. And some of priority areas have listed down in red, particularly accreditation programs. I think just training them alone is insufficient. We need to accredit. We need to have the process whereby there's continuing education for the genetic counselors and so on. You're not supposed to read the panel on the right, but just to say that we have actually done surveys among many of these countries in Asia. The last few slides, I'll just like to focus a little bit on public health genomics. And this is something that we are very passionate about because we feel that in a large population setting, little bits of action that are effective will translate into huge returns. Okay? So we look at SDGs, for example. We identified some of the bottlenecks and some of the interventions that can be done. And we focus on two important issues, thalassemia and inherited metabolic diseases. And of course, in the post-pandemic world, many of these programs are in jeopardy. But nevertheless, we need to kickstart some of these projects. And some of these SDG goal number 3 in health, shown here, you find that most countries in Asia Pacific region, the infant mortality rate has dropped due to concerted efforts by various quarters. But you find that if you look closer, the infant mortality rate due to congenital disorders had not changed. All right? And that's where we had to move in and do something about that. And of course, congenital disorders remain a condition that lacks recognition. And many of these meetings, for example, the International Conference on Birth Defects and Disabilities and various other meetings, it's been concluded very strongly that we really need to move on congenital disorders to reduce infant mortality rate so that we can achieve our SDG goal number 3. Otherwise, we are not going to get there by 2030. So one of the things that we looked at was trying to get all the countries to start expanded newborn screening program. And one of the things that we need was to consult some agency who has funds. And most of them turned us down, except for International Atomic Energy Agency, IAEA. Now, surprisingly, as it may sound, they were very keen to support newborn screening for hypothyroidism